Good morning and welcome to the March 2016 live Q&A call for aEEG Coach. And my name is Kathy Randall, of course, and I'm here to answer your questions. And I'm excited that we have someone on the line live today, and so we're going to actually be able to answer some questions. And so I'll just say a quick thank you to Mary for being here and for actually emailing in a question ahead of time. So I was able to pull up a slide for her so that we can actually chat about her question. So Mary, do you want to just quickly ask your question verbally since we have the line open, and then I'll pull up the slide and chat a little bit about my ideas.
Sure. So my question is about placing the needles. We used it our first time on a baby a couple weeks ago, and we parted the hair and we marked, and then we went to clean with the CHG, and it totally just wiped off the mark. So we're like, okay,
yep.
So how do you clean and then how do you mark and then clean without wiping up your marking exactly where you're supposed to put your needle? So maybe my flow is wrong, or I'm missing a little tip or something.
Yeah, no. So the pins that most of us use are water soluble, and so CHG is partial water, so it is going to remove it. The same happens when we do hydrogel electrodes because we're exfoliating the skin, and so we actually remove that little bit of the ink as well as that. So my advice would be to prep one site at a time, so you have the mark on one site. So I brought up this picture, just it's for hydrogels, but it will apply for needles as well. So if you look at the upper right-hand corner where you've parted the hair, and then you're getting ready, the next step would be to prep the skin. So what I would say if you're using a CHG little either saturated sponge or something like that, is as you're actually prepping the skin, I don't know if your protocol is to go in a circle or if it matters really, but I would say try to prep in the part, and then like you're doing in the next slide over, which would be the middle second row where they have kind of the little, I guess this is like a 4x4, and they're using it like a squeegee, where when you're actually prepping, I would prep from both directions away from the part, and then that way you're able to maintain the part, which will be kind of your landmark. And that way you're not just scrub in a circular motion and kind of disrupting that part. And then if you need to either hold or go up and down in the part where the actual needle is going to go, then that's what I would do, is just try to maintain that part by kind of doing a squeegee action, kind of going left and right, and then maybe even just doing a little bit up and down and then reparting. That would be what I would do. I don't know if does that seem like that might help?
Yeah, I think we wanted to use the CHG on the actual site that we're using for the needle, to clean really well.
Yeah, for sure.
So, I think that makes sense to me if we clean it such that the part remains bald, the area remains bald, then we will know that's where we're supposed to go. So I think some of it is practice and really get the hair parted.
Yeah, and so you can kind of see that in this example, in the second picture, we actually use a toothbrush, and I've actually used this really literally around the world where we have kids with super long hair, and I know probably in your community you have kids with thick, dark hair. And so using a toothbrush actually allows you to get a very, very, very tight part. I mean, really good. The other trick that we've done a lot is to use a tiny bit of KY and especially for long hair. So like this baby has really long hair in this picture. You could actually use a little bit of KY jelly, almost like a hair gel, and push the hair away to the edges and lay the hair down. It's a little bit like what we would do for putting a scalp IV in to make the hair more tacky so that the tape actually will stay. So it kind of can serve two purposes. And the other thing I would recommend is prepping, like I was saying, prepping one at a time. That way, if you kind of do mess up your part, you can just really quickly, since you'll have the other dot, you can reline up your measuring tool. So are you using the measuring tapes?
Yes.
Okay, so then if you've got your one dot and you know that that's the posterior or the parietal dot, then if you just quickly put your, you put the, the measuring tape back up, you can kind of redefine where that mark was and just validate, okay, I parted, I prepped, and do I have my mark where I want it? And then you can maybe reestablish some other kind of landmark. And if it's possible, even just insert and prep that one and then do the other. So just depending on kind of how the workflow makes logical sense or makes sense for that baby. But those are some ideas, but definitely, and I even just mark, on the measuring tape, I take my pen and I circle which letter. So in case I, really get off or need to come back, I just remember for that baby, oh, it was a B and a B. And I can just quickly recite my locations with that. And when you're inserting, remember that the dots are really, these were invented originally, these measuring tapes were invented for the hydrogels. And so the hydrogel, the dot is really where the center of the hydrogel should go. So another thing to remember is when you're using needles is you want to insert in the skin a little bit above that so that the actual needle is going to rest in the place where that electrode would have been. So if you actually use the dot as your insertion site, you're actually going to end up lower than you need to be. And that's going to just give you more risk for muscle artifacts. So kind of thinking about that dot as the actual place where you want the needle as it resides under the skin to actually be. Is that making sense? I hope. So
the place where I'm marking the dot
is where you want the needle to terminate.
Okay.
Does that make sense? So you're going to need to puncture the skin a little bit above that, more towards the crown, so that as the needle kind of slides in, the actual needle itself will be kind of underneath where that dot was, kind of center it up a little. Okay.
Yeah, that makes sense.
Okay, cool. So anyway, I think just using the CHG pledget or whatever you have to kind of, as you're establishing that part, going right and left, and you should definitely be getting enough cleansing across that center point where the actual insertion is going to be by going left, right, kind of, doing that should be okay.
Okay.
Any other quickie questions or long questions? Doesn't matter. Time is yours.
So the baby that we have done it on once, it seemed like I don't remember what side it was, the right or the left, the baseline was higher than the other side. And I don't know if that was related to the needle placement, like they weren't exactly
the distance.
Equal distance or on the same kind of sections of the head, like one was a little higher and one was a little lower. Would that make one side baseline be elevated?
So usually it's more about distance.
Okay.
So the distance of the electrodes will cause a difference in that. My question would be in that way, if you felt like it was lower, and what we were just mentioning is if you get too low, you end up with a lot of muscle artifacts. If you end up with a lot of muscle artifacts for that baby, you're going to end up having the lower margin on one side will be elevated because of all that noise. So it would be good to go back and look at the actual raw EEG and see if you see any of that kind of fast and fuzzy muscle artifact on the actual tracing that had the elevated margin compared to the other side. So maybe the other side was up higher. So what I do when I'm in class is I have people take their fingers and put them on their scalp right above their ears, and then I have them bite down. So you can do it too as you're kind of listening. So you can touch above your ears and bite, and you can feel those muscles, those tensing up. And then as you go higher, you can keep tensing those muscles, and there's a place on your scalp where that muscle, you can't feel it anymore. And so if you have a baby who the electrodes are a little bit low and they're sucking on a pacifier, if they're, relatively well, or they're crying, all those muscles, even facial muscles, are going to activate, and the electrodes just pick those up. So if you're able to, actually, let me just I don't know what my hair looks like today, but we can all do. So what I was saying is like here. So if you touch here and you bite, you can actually feel those muscles. And as you put your fingers up higher, you go a little bit higher and a little bit higher, and this is actually where the electrode should go. It's like right up in here. So if you actually can feel right here, you can bite and you can't feel those muscles anymore. So that's where you want the electrodes, is up high enough. And that's why I was saying if you start above and go down, you won't end up in that place where you get that muscle artifact. So if you had one side a little bit lower and you got all this muscle artifact kind of pinging off, and this side is normal, this side is going to actually elevate the baseline because all that artifact is in there, fuzzy, 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 fuzzy. So you don't have a chance for that signal to degrade ever and to get your bottom margin. So it's falsely elevating one side, and the other side might have been really the really good representation. So that's one idea. When you have asymmetry, is do you have asymmetry of location this way, or do you have location separation? Like, so is it really wide on one side and really narrow on the other? So that would be the other cause for asymmetry of that. And of course, the worst of all is stroke, right?
Right. Well, it wasn't, yeah. So, and to really clarify whether, the asymmetry.
What it was. Mm-hmm.
Yeah, you need to go to the raw EEG. Is that correct?
Yeah. Yes, correct. So anytime you want to investigate more of the actual nuances of the aEEG, you're just going to touch the monitor screen and you're going to go into that review mode, and then you're going to scroll through the actual EEG. And in this case, if it was lower and the kid was active, the lower margin was elevated and the kid is really active, it's probably muscle because he's moving and squirming. I mean, I don't know if that's the case for this baby, but any kid who's more active, you're going to see that.
He was active at the very beginning, yes.
Yeah. So it would be good. You can take a couple snapshots and we can review them.
Okay.
You can do
and
screenshots of that.
I can review the raw EEG on the OBM monitor?
Yes. Yeah. So there's a toggle at the bottom of the screen where you can switch between the impedance reading and the EEG reading.
Yes.
So
okay.
So there's either the little kiloohms, so it's the little circle.
Right.
That's the kiloohms. That's for impedance, and that's going to give you your impedance graph. And then if you toggle to the one that looks like EKG, like this, it's going to have the EEG, actual raw EEG will be there. And you should be able to see it even after the fact.
Okay. All righty.
Yep. So that would be, and I recommend that you just leave it on the EEG trend, or, so you have your aEEG at the top and you want to have your live EEG or your raw EEG at the bottom. I just leave that on because the impedance, if your impedance is elevated during the recording, you're going to have other flashing warnings at the top. So it's going to tell you that something's been dislodged, or it'll tell you that something else is going on. So you don't need to really be watching that trend. That trend is so boring. You want to see the EEG because that's where you'll be able to really see if it's seizures, if it's artifacts, if it's stuff like that.
Okay.
So that would be my recommendation for kind of your standard setup would be, after you get it on, you evaluate the impedance. Your impedance is good, especially with needles. That impedance is going to be so boring. There's nothing to see because it's so stable. It's not like with hydrogels where it moves around. And I don't know what you're doing for documentation, but we have our nurses where I work up at Stanford. We still evaluate that every 3 hours. We at least look at the impedance and we document those values.
Right. Yes, they're going to be looking at that every couple hours.
Yep, that's good. And with needles, it's very, very stable, especially if you secure them well.
Okay.
Yep, you shouldn't have any issues.
How do most people secure the needles? Do they use just regular Tegaderm?
They do it like a scalp IV. Yeah. So you're going to chevron them, so go up and around, and then just a piece of Tegaderm or just silicone tape or whatever you have. You can just put that over it. So just like a scalp IV.
Okay.
Mm-hmm. Yeah. Great question.
Okay.
Let's see, I'm trying to think. Is there anything else you can think of?
Not right at the moment.
Okay, cool. Well, I'll dive into my few little tiny slides that I prepared just in case we didn't have any questions. So basically, I was thinking this morning, like, what are the different ways that people are using aEEG? And so I kind of divided it up into 3 ways that you could use, or that we should be using aEEG in the NICU. And the first is a screening tool. The second is as a clinical assessment. And then the third is as a research device. And so when I think of the aEEG as just a screening tool, this is for places that actually have real EEG capabilities. So you have access to video EEG or full conventional EEGs, and so that we would use the aEEG as a screening tool. So I like to think of it much like a 3-lead ECG or EKG, where if I see a funky something, an arrhythmia, then I'm going to escalate from there to a full video EEG. I might get a consultation. We might consider medications, those kinds of things. So we use it in those times where we have gaps in service, so maybe middle of the night, times where there's just resources and we don't know whether or not we should, transfer the baby or not transfer the baby. So I think it's a tool where we can use to screen and then decide if we want to do additional interventions or consultations. Then as a clinical tool, so whether or not you're using aEEG or full video EEG that can display aEEG, so I talked about that last month as like the different kinds of monitors that are out there, we can actually use it as our clinical assessment tool. And I put here something is better than nothing, because for some units, this is all you have, and that this is definitely, with its limitations, it's still acceptable to use, and understanding that it does have limitations, that if it's a small seizure coming from the occipital lobe, you may or may not see it on your C3, P3 aEEG. That maybe short seizures you're not going to be able to find, but that at least you're trying to monitor background, you're at least trying to be able to see some seizures, and of course you're trying to evaluate sleep or symmetry and other things that might justify, again, transfer or things like that. But I think something is always better than nothing when it comes to the brain. You could use it, for example, we have some larger devices that are full video EEGs, full video EEGs that can display aEEG, just 2 channels. And I just had this situation last week where we have a baby on full video EEG, and we have the aEEG showing at the bedside, and we were able to identify a kid in status at around 6 in the morning. And luckily we had our neurologist in-house, and we could contact them and just say, hey, we are seeing this uprising on aEEG. What's going on? Can you evaluate that? And in fact, the baby did have status. It was in fact coming from the occipital lobe, but we were able to see some carryover into the central zone. And so we were able to get that seizure managed pretty quickly within an hour, and we're able to see the effect of that treatment on the aEEG as well. So yeah, the neurologists were guiding us and teaching us and, validating that what we were seeing was true seizures, but certainly we were able to see the effect of that on the aEEG in real time, and that was really, really helpful. Then the final way to use aEEG is, of course, in research. And of course, there's still a lot of unanswered questions, and people are certainly continuing to develop more and more uses for it and to validate those uses. So I just encourage everyone, if you have a device, whether or not it's through a quality improvement project of just evaluating your own kind of local practice, how frequently you're using it, and how you are, in fact, using it compared to your protocols, I would just say go ahead and study what your use is and see how that's going for your team. So plenty of, full-on randomized control trials that still need to happen. And, I encourage anyone to do that as well. So really a fun tool to use. But of course, these are huge projects sometimes as well. So that's why I always say quality improvement projects are still awesome, because it really talks about your specific practice and how you're using the device. So you can say, since we started using aEEG, are we getting more neurology consults? Are we getting more full video EEGs? Are we using more or less medications? Are we using medications differently? A lot of places who've done quality improvement projects notice that their trend in how they use, say, for example, phenobarb completely changes, that they actually end up using it on fewer babies, but the babies who get it get a lot more because we're actually able to see the subclinical seizures. So I think it's important to think about ways to use it in formal and kind of informal research and quality initiatives. So those are just my three little ideas that I wanted to share this morning. Our next live call will be April 25th, 8 a.m. Pacific, 11 a.m. Eastern. Please, like Mary, email in a question, then we can have a chat about those. And I just invite everyone to continue to join us for these calls. They're included. They're for you. They're to help improve your practice. So Mary, any final questions? Or any comments about what I just presented or anything?
No. Ours is just we have access to full EEG when we absolutely need it. So this will be, I'm hoping, and our doctors are very excited about it, so I'm hoping that we'll be using it on a variety of patients. So,
do you know what kind of EEG machine you have?
No.
So it's
we
good
don't
to chat. And ask.
Yeah, if the doctors are ordering a full EEG, then they come up from neurology and put it all on. So
right. So the question will be whether or not if your full video can. Oh, go ahead.
We don't have video capability.
Okay, so no video.
No.
Just full montage. Video is really helpful, and so maybe as you're expanding your practice in this way, the next time they need to buy a device, it might be good to have that. Just babies are so much artifact. It's so helpful to have the actual video, and I'm sure your neurologist would love that. But of course, it's always resources and things, and there may even be a way to add video, like a video module to the device you have. That would be cheaper than buying a whole new device. The other is to ask whether or not that EEG device has trending tools. So I know, for example, the Viasys Nicolay 1 has an aEEG module. So when the full video EEG is running, you can do like what I was mentioning, which is where we can still see aEEG on the actual video EEG machine. We don't have to run both machines at the same time. And this will be a question too, is if you identify a kid that you do want to change or add to video EEG, are you going to take off your needles, or can you do them at the same time? And so for a lot of years, we didn't use aEEG on our video EEG machine. We ran both devices. So it may be that you decide to look into that and say, hey, if we can see the aEEG trend on our video EEG, we don't need to keep both on. But if our video EEG can't show us the trend, well, then we're kind of back to where we used to be, which is where we're dependent on someone else reviewing it in whatever time they're planning. So I think those are good conversations as you start to monitor. It's, when we order it, what are we going to do? Are we going to leave it on, take it off? What should we do?
Right. Okay.
But certainly it's nice when your full video EEG has the aEEG algorithm embedded, because then you get a 2-for-1, and then you can still read the trend, which would do like what we were saying, what I did last week, which is like, oh my gosh, we're seeing something on aEEG, and then you get that backup. And that's like the best of both worlds.
Yeah.
And if you leave your aEEG on, you would still be able to use it in the same way. You could say, on the central and parietal lead, we're seeing this. What are you seeing on the full recording? And you can have that dialogue at times when they're not reviewing. Because the standards are really pretty minimal as far as how often they log in to look. And if it's a busy off-site neurologist who's seeing patients and this and that, there's a lot of times where there are many hour gaps between when they're just able to even look in. In our review, it's required within 2 hours of the onset of recording, and then twice daily. That's all they have to do their review. Then they write a report on that 24-hour segment. So it's continuously recording, but not continuously being reviewed. That's why aEEG trending is so powerful, because the trending is available for us at the bedside, and we can see something faster.
Yeah.
So,
okay.
So fun stuff. Fun.
Yes. Thank you.
All right. You're very, very welcome. Well, thanks for joining me live, and then I hope more people will join us next month.
I hope so. Okay, thank you.
All right. Bye.
Bye.